Goals for treatment for metastatic disease typically are to control the disease and maintain or improve quality of life. Um, there are options, and that's a great thing. So we have more and more drugs that are approved for the disease, and so we have to begin thinking about sequencing therapy, which is much like what we do for colon cancer. So as a GI medical oncologist, we're used to that, but it's something that you need to think about. You know, most patients are likely to get a second and third line therapy, so I'm not sure that doing a three-drug regimen in the first-line setting adds that much value, and it does certainly add toxicity. Um, in terms of three-drug therapy, the clinical trial data started with the DCF regimen, which was published in 2007, so already 10 years ago. That regimen is almost never used at this point because of toxicity. 80% of patients develop grade 3 neutropenia, mucositis, diarrhea. It's a tough regimen, but it did improve survival over a two-drug regimen. The argument from our Asian colleagues was always that if you could sequence therapy, you could get the same or better survival. And that I think that may be true. But since the DCF regimen was so toxic, there have been really many efforts to try to improve that regimen to mitigate toxicity and perhaps improve outcomes. So we actually published a couple of years ago the modified DCF regimen, which is a 48-hour infusion of 5-FU administered with docetaxel and cisplatin. And that three-drug regimen was compared to DCF in the phase 2 setting, and it really had, I would think compelling data or compelling outcomes. Median survival was 16 months, which is really quite impressive. The FLOT regimen developed in Germany is a similar regimen. The differences are as follows. The 5-FU is not a 48-hour infusion, it's a 24-hour infusion, so it's a high dose, 2,600 milligrams per meter squared, IV continuous infusion over 24 hours, oxaliplatin instead of cisplatin, and docetaxel is the same. And that FLOT regimen is also very active in the metastatic setting. So I think in select cases, you might consider a three-drug regimen, but most patients, I think, would get a two-drug regimen. In the second-line setting, we ask the same questions in terms of goals of care, and I think depending on performance status and comorbidities, most patients would get a second-line regimen. Most often it's Taxol and Cyramza, which is ramucirumab. Ramucirumab is the second targeted agent that was approved in gastric cancer. It's a VEGFR2 inhibitor, and it has clear activity. And then if they progress on that and they're PD-L1 positive, then pembrolizumab is an option. If PD-L1 negative and they're still a candidate for therapy, then we would typically go to irinotecan. I would say that this sort of typical sequence of treatment options is likely to change as we get more drugs approved in the disease. So about 5 years ago, the TOGA study demonstrated the efficacy of the addition of trastuzumab to cisplatin 5-FU, or cisplatin and capecitabine in HER2-positive gastric cancer. So just like in breast cancer, HER2 is a membrane-bound receptor that acts as a co-receptor for HER1, HER3, and HER4, and it actually drives cell division and cell survival. And so blocking HER2 has a therapeutic advantage, and that's what the TOGA study showed. And ever since then, for HER2 positive patients, trastuzumab really should be considered. So that's now a standard as part of our practice. We check all patients for HER2 expression initially by IHC, and then if they're HER2 IHC 2+, we also do FISH. And if they're FISH positive, then we are able to give trastuzumab. HER2 activation and its significance is different in gastric cancer and breast cancer. So in breast cancer, you often continue trastuzumab into second and third line treatments, but in gastric cancer, there's no data to support that. And in fact, the second line studies for gastric cancer, both with apatinib and with TDM1, have been negative. So I think that our best option is to try to use trastuzumab in the first line setting, and if patients progress, then discontinue HER2 targeted therapy and move on to standard second line therapies.